Swayam Prabha. Digital India. Educated India.
Welcome. This session will be on pathology of oral cancer, and oral cancer will be studied under the following headings of etiology, pathogenesis, molecular biology, the precursor lesions involved, the pathology including the sites, the morphology, and finally the clinical features. So, now oral cancer is under the broad category of head and neck carcinomas. What they have noticed is that 95% of head and neck carcinomas are squamous cell carcinomas. The remaining 5% are mostly the salivary gland tumors. Now, these head and neck squamous cell carcinomas are the 6th most common neoplasm globally. Now, whenever we say head and neck carcinomas, these include malignancies occurring in the following anatomic locations of oral cavity, pharynx, larynx and the nasal cavities. Today, we will be concentrating on oral cavity, pharynx, especially the oropharynx. It is basically multifactorial. Now, earlier it was thought to be mostly related to tobacco, but since a few years we have noticed that high risk human papillomavirus is also a factor in the pathogenesis of head and neck squamous cell carcinomas. Besides that, actinic radiation, chronic irritation especially by ill-fitting dentures, then immunosuppression etc. are also responsible. So, the first one is tobacco. Most often it is smoked tobacco, especially in western countries, but the increased incidence of oral carcinomas in other countries like Asia, India especially, it has been noted to be due to chewing of betel quid and pan, which has certain carcinogenic agents in the form of arecanut etc. And pipe smoking gives rise to carcinomas of the lower lip. This is in association with actinic radiation. Now, the next one, the most important one is human papillomavirus infection, because it accounts for approximately 50% of oropharyngeal carcinomas. The primary cause is the high risk HPV, which include HPV type 16 and 18. The remaining etiopathogenetic factors include chronic irritation of the mucosa by ill-fitting dentures etc., immunosuppression and alcohol. So, oropharyngeal carcinomas and oral cavity carcinomas, the causative agents are a little different. Oropharynx is predominantly virus related, specifically HPV type 16 and 18. Now, whenever we say oropharynx, we mean the especially in case of oropharyngeal squamous cell carcinomas, we mean the locations where the tonsils are, which include the lingual tonsil, which is there in the base of the tongue, the oropharynx and the palate. Then these are detected late because the lesions are usually small and they are not accessible to screening. HPV 16 is detected in most of these cases, that is at least 50% of these cases. Oral cavity lesions are not associated with human papillomavirus. Tobacco is the main cause, and tobacco gives rise to field cancerization, that is the multiple areas in the your oral cavity would be affected by the cancerous agent, and therefore, multiple primary tumors are common. Now, the initial tumor after that is detected, the second tumor is usually fatal and it occurs at a rate of 3 to 7% per year. Now, once the first one is detected, 5 years post detection, 35% chances of the second primary occurring. So, molecular biology of head and neck squamous cell carcinomas, it usually is because of the carcinogenic agent affecting the oncogenes and the tumor suppressor genes. This is by mutations or epigenetic changes, and this gives rise to a lot of functional changes, that is the genetic function is altered. So, these changes include loss of heterozygosity, copy number alterations, hypermethylation, RNA expression alterations and somatic DNA mutations. following several studies, especially on genome sequencing in these tumors, and the most predominant one being the cancer genome atlas. A lot of important findings were there regarding the mutational landscape in squamous cell carcinoma of the head and neck region. These include that some mutations are very common and they act as drivers to cancer development, that is, they start the whole process, and these include TP53, CDKN2A, that is your cyclin dependent kinase inhibitor, that is, then PIK3CA. Now, besides that, some others were also discovered which were there in some and not present in some of the tumors. So, they were thought to be acting kind of like passengers. So, these include the Notch1 and its pathway, and FAT1, that is a tumor suppressor gene belonging to the cadherin family. So, right now they are trying to use these for targeted therapy. So, potential targeted therapy agents are these. Then what they have realized that though P53 mutation is common, the other mutations they differ in different individuals. So, the same tumor, there is heterogeneity for mutation. So, there is intertumor heterogeneity. Then different mutations are seen in human papillomavirus induced malignancy and non-HPV head and neck squamous cell carcinoma. So, P53 and RB protein tumor suppressor gene mutations are more common in HPV induced tumors. Okay, precursor lesions are usually seen in non-HPV induced tumors, and these are seen in oral cavity as a predominant site in middle-aged individuals and a little elderly individuals belonging to the 40 to 70 years age group, with a male is to female ratio of 2:1. It is multifactorial, but mostly associated with tobacco products. So, where will it be seen? It will usually be seen wherever tobacco products accumulate. So, this is seen along the tongue, the gingiva, the floor of the mouth, the lips, etc. So, there are two types of lesions. The first one is leukoplakia. As the name suggests, it is a white plaque. Now, WHO has defined it as a white patch that cannot be scraped off and cannot be characterized clinically or pathologically as any other disease. Its incidence is 3% and 5 to 25% of them are pre-malignant. So, not the remaining up to 75% may not be malignant at all or pre-malignant, in the sense it may not give rise to squamous cell carcinoma. The other one is erythroplakia, though it is less common. This is associated with a higher degree of progression to malignancy, and therefore, it is more important, and more atypia is seen in these cases. So, grossly how do they look? So, first we will look at leukoplakia. Now, in the picture you can see a small white plaque which has very well defined borders. It is little irregular. So, they can be solitary or they can be multiple patches and plaques. The sites are where tobacco will accumulate, that is in the buccal mucosa, the floor of the mouth, the tongue, the ventral aspect, the palate and the gingiva. Surface is smooth and thickened or wrinkled, fissured, sometimes corrugated, even verrucous, and it will usually be elevated. Erythroplakia, meanwhile, you get red, it is red plaque. So, it is a reddened lesion, it is velvety, it is eroded, it can be level with the surface or it can be slightly depressed, but it is never elevated. Microscopically, leukoplakia, this is a lesion microscopic picture of leukoplakia. What you see here is full thickness actually dysplasia. So, involving the entire thickness of the squamous epithelium. There is hyperkeratosis and there is acanthosis. That white color in leukoplakia is because of hyperkeratosis. So, it is an essential feature. So, increased thickness of the stratum corneum. So, here actually you are even seeing nuclei, that is parakeratotic. So, hyperkeratosis with acanthosis. Acanthosis is thickening of the squamous mucosa and dysplasia. Now, the dysplasia, it depends. If it is in the lower third, then we call it mild dysplasia, that means it is maturing further, or upper lower 2/3 we call it moderate dysplasia, that means the superficial layers are mature, and full thickness dysplasia can also be seen. Now, a pre-malignant lesion with no disruption of the basement membrane is known as carcinoma in situ. So, from mild dysplasia to carcinoma in situ we can see in leukoplakia, whereas In erythroplakia, it is usually severe dysplasia. Sometimes it can be carcinoma in situ or even minimally invasive squamous cell carcinoma. Now, why do we get the red color? The red color is because of the extensive dilation below the epithelium, which means in this locality. So, over here you will get extensive dilation of blood vessels along with plenty of inflammation, and that gives rise to the red color. That is why it is known as erythroplakia. So, remember, leukoplakia is hyperkeratosis with acanthosis, mild to severe dysplasia and or even carcinoma in situ. Erythroplakia is severe dysplasia to minimally invasive squamous cell carcinoma with subepithelial vascular dilation and inflammation. Next, we move on to squamous cell carcinoma. Now, there are two types, non-HPV associated and HPV associated. So, initially we will have a look at non-HPV associated squamous cell carcinoma. Grossly, the location is the same as leukoplakia. So, we get it on the ventral surface of the tongue, floor of the mouth, the lower lip, soft palate, gingiva, etc. Grossly, initially it is a raised, firm, pearly plaque almost similar to your leukoplakia. After that, it becomes irregular, roughened or verrucous with a background of leukoplakia or erythroplakia, and finally it becomes a large mass which protrudes on the surface. It may ulcerate, the margins, when it ulcerates, the margins are rolled out and the base is indurated. This has an irregular surface also. So, this is how it will look grossly. This is an ulcerated lesion. So, this is the progression from mild, first hyperplasia to mild dysplasia to moderate dysplasia, severe dysplasia and carcinoma in situ, and finally to invasive malignancy. Likewise, the gross picture also. Here it has protruded and ulcerated. There is a gross exophytic lesion which has ulcerated. In these initially you may not even be able to see it. Later on there is just mild leukoplakia. Then the leukoplakia progresses to an invasive malignancy. Microscopically, the most important aspect of non-HPV associated squamous cell carcinoma is it is keratinizing, there is abundant keratin. So, this is how it looks microscopically. Here it has infiltrated into the stroma and there are a number of keratin pearls, which means that this is a keratinizing squamous cell carcinoma. So, in this invasive squamous cell carcinoma, it can be well differentiated wherein the keratin will be abundant, or it can be even poorly differentiated, sometimes even anaplastic or even sarcomatoid. Now, in poorly differentiated, the keratin amount of keratin is lesser. But irrespective of that, the degree of differentiation, it has no effect on the clinical behavior. Now, over the years we have discovered a number of variants of these microscopically, and these include acantholytic, adenoid, basaloid, then carcinoma cuniculatum, papillary squamous cell carcinoma, spindle cell squamous cell carcinoma, and the lymphoepithelial carcinoma. Verrucous carcinoma is a specific variant of squamous cell carcinoma which has an excellent prognosis. We will be dealing with that later on. Now, we move on to the HPV associated squamous cell carcinoma. Grossly, it is a very small lesion and absolutely no precursors are seen, or at least we have not detected any precursor lesion till now. The location is wherever the tonsils are, which means base of the tongue, then oropharynx as well as in the palate. So, lingual, soft palate and pharyngeal tonsils. In that, where does it affect? It will affect the epithelium overlying the lymphoid tissue. So, epithelium and the lymphoid tissue are in close approximation here, and that is what we will see microscopically also. Now, most of the time the lesions are so small that the associated cervical lymphadenopathy, which is often seen, brings to notice the lesion. So, when we detect the lymph node enlargement and subsequently try to investigate the patient, an oropharyngeal malignancy is detected. So, how will it look microscopically? As I said earlier, this is a lesion occurring in the epithelium of the tonsillar crypts. Therefore, it is in close association with lymphocytes. Most important aspect is that it is non-keratinizing. So, what you get is nests of basaloid cells. So, what are basaloid cells? Basaloid cells are there in the base of the stratified squamous epithelium, that is the lowermost layer. They have very little cytoplasm and are almost bluish in color in hematoxylin and indiosin stained sections. Now, in these condition, that is HPV associated squamous cell carcinoma, these nests of malignant cells are in close approximation with lymphoid tissue, somewhat similar to what is normal in the tonsils. Now, when you do immunohistochemistry for a surrogate marker for HPV, that is a P16, we will get diffuse strong positivity in the nuclei. By even cytoplasm can also stain it. Now, by diffuse we mean more than 50%, actually here it is almost 100% staining of the cytoplasm as well as the nuclei with strong intensity if it is HPV associated. Now, further if we try to do in situ hybridization, in that this E6 and E7 of the high risk HPV is expressed. So, what happens to this squamous cell carcinoma? Initially there is local infiltration, after that there is metastasis to the draining lymph node, then subsequently followed by the other lymph nodes. Hematological metastasis can occur to the lungs, liver and bones. So, what is the prognosis of this tumor? Now, prognosis wise it depends on whether it is HPV associated or not associated. With HPV associated squamous cell carcinoma having a much better prognosis, and the 5-year survival of these tumors in early oral carcinoma it is 80%, late stage it is 20%. Now, besides that it also depends on field cancerization. So, field cancerization is nothing but multiple primary tumors occurring in the oral cavity or head and neck region in maybe contiguous sites or in the same site or a little away from that site. So, this is thought to be because of the carcinogenic effect of whatever the agent is that has caused. The degree of dysplasias initially may be different in different sites. So, as a result of which the primary tumor can occur at different duration or at different times in different areas in the same person. So, this is very important because whenever the second primary arises, it usually causes fatality. Now, these tumors are staged as per the PTNM or pathological TNM staging of right now we use the American Joint Committee on Cancer 8th edition, in which the tumor stage depends on whether the tumor is in situ or then it is divided into T1 to T4. Now, whether it is less than 2 centimeters or 2 to 4 centimeters or greater than 4 centimeters and with depth of invasion less than 5 millimeters, more than 5 millimeters or more than 10 millimeters of depth of invasion, and likewise whether the tumor has infiltrated locally or extensively, that belongs to T4. Now, in the nodal staging, we look at the size of the metastasis in the lymph node and whether ipsilateral or contralateral, ipsilateral and contralateral or extensive nodal involvement is seen. And size wise it should be either less than 3 centimeters or 3 to 6 or beyond 6 centimeters, and whether extranodal involvement is there. So, that is ENE. So, DOI is depth of invasion for the primary tumor staging and ENE is extranodal extension for the nodal staging, M is for metastasis, which is distance. So, if DOI and ENE are there, so even if size wise whether in the PT stage or PN stage it belongs to a lower category, the minute DOI is there the PT stage will upstage, and the minute ENE is there the nodal stage will upstage. Now, this is a beautiful representation. As we see, the HPV ones occur in younger individuals. Location is usually the oropharynx, risk factors are different. Clinical presentation, it is a small lesion involving the cryptepithelium. Histologically, there is no keratin. Distant metastases are uncommon and clinical outcome is very good. Risk of second primary is low, whereas in those which are not associated with HPV, but associated with other risk factors, most important being tobacco and alcohol, the location is usually in the oral cavity with a large primary lesion. Metastasis is common, the histology shows keratinization with varying degree of differentiation and sometimes even variants. clinical outcome is not as good as the HPV associated squamous cell carcinoma, and because of field cancerization, risk of second primary is definitely there. More in detail about the same. So, precursor lesion which is seen in those not associated with HPV is leukoplakia or erythroplakia. Then site in the oral cavity includes tongue, floor of mouth, lower lip, soft palate, gingiva. Grossly, it is a large raised lesion with induration of the base as well as rolled out margins, and it is irregular. Microscopically, as I said, it is keratinized. So, it could be well differentiated squamous cell carcinoma, or it could even be anaplastic. Lesser number of lymphocytes are there, and immunohistochemistry when you do for surrogate marker of HPV, that is P16, it is negative. Whereas, in HPV associated head and neck squamous cell carcinomas, the site is the crypt epithelium of the tonsils. So, wherever the tonsils are located, which means palatine tonsil, the lingual tonsil at the base of the tongue, or adenoids. Grossly, it is a small lesion which is usually flat and not raised. Microscopically, you get basaloid cells in nests along with lymphocytes as seen in the normal tonsil, and when you do immunohistochemistry, it is diffuse and strong positivity for surrogate marker of HPV, which is P16. Now, lastly, we will just have a look at verrucous carcinoma. Now, this is a carcinoma which is an excellent prognosis and was discovered by Ackermann, and hence it is known as Ackermann tumor, usually seen in oral cavity with the same locations as the non-HPV associated head and neck squamous cell carcinoma and almost similar etiopathogenesis. The age group is also similar, it occurs within the age group of 40 to 60 years, males more often, and tobacco is the main association. HPV, some say yes, around 28% of them are associated with human papillomavirus, and as the name suggests, it has a verrucous appearance, that the gross and the microscopy are very classical for this tumor. Grossly, it is a warty, verrucous, verruca means a wart. So, it looks like a wart, so warty, but it is a huge warty lesion and exophytic with papillary excrescences, sometimes can even be red. Now, this is characteristically a locally infiltrating tumor which recurs and is non-metastasizing. Excellent prognosis, and microscopically it is characterized by a well differentiated squamous cell carcinoma with no atypia seen, bulbous retipex. The reti are nothing but the extension, the lower extension of the stratified squamous epithelium. So, these are bulbous and they are growing downwards and inwards with these reti showing keratin pearls. So, this is very classical for well differentiated for verrucous carcinoma, and there is also a lymphocytic inflammation seen just below the expanding or infiltrating nest. Now, the margins of this is blunted and it is not irregular as is seen in classical well differentiated squamous cell carcinoma. So, this brings to conclusion the head and neck squamous cell carcinoma. So, let us summarize the entire class. So, what did we learn? We learnt that head and neck carcinomas are predominantly squamous cell carcinoma. There are two types, HPV associated and those which are not associated with HPV. Molecular biology is varied. TP53 and RB inactivation is more specific for HPV association, and your cyclin D kinase inhibitors are also seen, especially in the non-HPV associated. Now, non-HPV associated squamous cell carcinomas are more common in the oral cavity. They are large, they are keratinizing, and they have poor prognosis. The HPV associated carcinomas are more common in the oropharynx. They have basaloid cells with lymphocytes and they are non-keratinizing with good prognosis. So, with that we finish with the verrucous carcinoma, which has excellent prognosis, but is a locally aggressive variant of well differentiated squamous cell carcinoma. So, that comes to the end of this lecture. Thank you for your attention. Have a good day.